And good morning or good afternoon, everyone, as the case may be for you. Welcome to PerfWeb. What number are we?
112.
112, day one. Thank you.
Yeah.
I appreciate that. I forgot what number we were on today. 112 programs. That's
a lot.
pretty
That's
amazing.
pretty
I think we've
significant,
done
yeah.
really well.
Yeah.
I'm excited about it. But anyway, I'm your host, Joe Basha. Let me go ahead and get you started on my regular housekeeping notes, obligatory opening remarks. To contact us, you reach out to that email address right there, contact@perfusioneducation.com. If you have an idea on a topic, which reminds me, there is somebody that has an idea of a topic. And if you're watching today by any chance, I don't remember his name right now off the top of my head, but I have recruited an excellent pediatric perfusionist to talk about the perfusion aspect. And sitting right next to me is a embryological expert who can talk about the congenital anomalies from a mechanical perspective and how they form and why they form, and then what has to be done to fix those. And then from the perfusion aspect, we're going to have a couple of very good pediatric perfusionists. So we are going to be doing that program coming up probably somewhere mid to late June or July in that time frame. So keep your eyes out for that. Next, if you notice down at the bottom, you see the crawl bar that's going across right there. That goes on and off continuously throughout the program. And that's how you can reach us if you're watching us on the YouTubes, if you're watching us on Faceplace, if you're watching us on X, or wherever it is you are watching us from, or our own internal system. For those of you getting CEUs, you can find all of the information that you need right there. And although I realize that it's always a pain in the neck, if you have not already done so, if you could like and share, it's a small thing for you to do, but it really makes a big difference to us and really helps to keep this program continuing. As you all know, all of our programs are actually free to watch.
Yes.
People can watch these programs, learn from them, interact with them, and participate in them, and be able to do so completely free. The only thing that you do have to pay for are the CEUs that will be issued if you need them. And we've got several different pathways for that. We have individual programs. If you go to the perfusioneducation.com, you can, of course, click your way to our library and see what programs we have available. We've got an ECMO course coming up, actually in June, the first weekend of June and the second weekend of June for the simulation session, but the didactic session. And if you go to can you show that mediweb.us? The ECMO program. If you go to mediweb.us, and we're going to bring it up on the screen here. There you go. The adult ECMO specialist training course. It's broken up into two parts. The full course is didactic. It's 2 full days of didactic, about 16 hours, and I think it's about a little over 20 ABCP Category 1 CEU, and then the simulation course is the following weekend here in Houston at Memorial Hermann, the Woodlands Hospital, in their education center, and it's really fantastic. But you can take a look at that if you'd like. I think it's really worthwhile. If you're an unlimited member of our PerfWeb programs or our perfusion education program, then the didactic portion is included in that. So I wanted to point out that when we say unlimited, we mean unlimited. We don't have an unlimited program that isn't really unlimited because you have to pay more for the ECMO course. The didactic portion is included in it. So if you buy it standalone, you'll spend a little more money. If you're an unlimited member of perfusioneducation.com, then that would be included in that membership, and you save a little bit of money. So entirely up to you all, but it's a really good course, and I highly recommend it. Our MediWeb app, which you can find on Google Play Store or the iTunes Store as an app. Not iTunes, but Apple Store, App Store, the Apple App Store. Thank you.
Yep.
You can go on there and you can find it. I use it every day. I use it for perfusion cases. I use it for NRP cases. I use it in the ICU when I'm doing ECMO. It actually has some very useful tools in it, and it's really, really inexpensive. I think it's $2.99. There is a separate standalone app. If you look at the bottom left-hand corner, the IV dose and rate calculator, and you look that up. But it can even give you the allowable blood loss if you're anesthesia. You put in the crit that you don't want to go under, and what the patient's crit is, and then it'll tell you how much blood you can lose replacing it with just crystalloid before you reach that critical threshold and have to transfuse the patient. So it's a really useful tool.
I like that. I didn't know that was even. I'm still I've only been using it maybe about 6-7 months, and I'm discovering new stuff in it all the time. I didn't even know there was that in there.
There's a lot in it.
There's a lot in there.
There really is. I know. Well, that's how I feel too. And then our podcasts, whatever your favorite podcast streaming platform may be, Podbean or Spotify or whatever it is, you can find us there. Type in PerfWeb, and you can listen to our programs that have been pre-recorded or participate in them. And yes, let's talk about some of the programs we have coming up. We have, of course, right now with us is Dr. Samir, and he is an MD and a perfusionist, and he loves perfusion, which I think is fantastic. And his program, Paging Dr. Samir, we have Vicki Carlisle's At the Bedside. These programs are up currently, and we have several of them there, so podcasts that you can listen to. We have Vitals and Vibes with Vivian Moreno. Becky Bolkovac will be doing her first program, You're Grounded. And then today we are going to be testing the Perfusion in Jeopardy game. And this is really going to be a lot of fun.
This is going to be fun.
But also very informative and educational. I am going to have it approved for Category 1 CEU if the board so agrees. But I think that it is a very useful thing for all of us to both recognize what we have forgotten from school and maybe should have and should still know. But of course, we have Dr. Google at our disposal. We can always find information out. But I just think it's a really interesting way to bring up topics that we just forget about in our daily practice because we're consumed with, we got to get this case done. What do I need to know about this particular case? Let's do it. We get out of there, we're done, the patient goes on their way, and we sort of forget about a lot of the other stuff, all the little things that we can do to make a difference.
It's always you can remember the 80%. It's the 20 that that get by you.
Yes,
the little things that we don't come across in our practice.
I think in my case, it's the 20% that I remember, and it's the 80% that I forget.
But what sucks is that it's when you forget that 20, and then you'll have that one case.
Yes.
Where you'll need to know that tidbit of information, and you would have since forgot it. And here you are pulling your phone out trying to Google it.
Well, one of my topics today, so if you don't mind me diverging off of this, and we're going to get to our first talk. We have 3 big lectures to do.
Yep.
All of them, I think, are to some degree controversial or can be controversial. And I think it's going to be interesting to have these conversations. And then I've got something here, Magic. Somebody is saying that they can't access something. Do you know what that's all about? You have to go to the. Say, I'm sorry.
He's from India, and we block India, China, and Russia.
Oh, okay. So for my dear friend over in India, the problem we have is that we are bombarded with bots, and so apparently whatever main domain, not your home, but where you're trying to log in from, somewhere out there in that country is a problem, and it's being blocked. So your service is going through some hub that we had to block because of all of the crazy bots that disrupt our system and will make our system crash. So I apologize for that. Hopefully, maybe you could get a VPN and try it that way would be my only suggestion. But getting back to what I was talking about, changing topics a little bit. We do have 3 really good topics, but the other day I was asked by a surgeon who said, "Hey man, I've got this case to do. This patient is really, really, really sick. I know they're an inflammatory mess. They've just kind of been languishing. And do you think you could do your special voodoo, he called it, that you do, which is CVVH?"
Sure.
And I'm going to talk about that today. The difference between cuff, muff, Z-buff, and CVVH.
Okay.
And the closest of those 2 is Z-buff and CVVH. But I have a particular technique in which I do this. And I did that very aggressively on this patient in for an hour and 45-minute, almost 2-hour pump run. I did 10 liters of CVVH on that patient. And it was, he really said, this is absolutely remarkable. The heart is less swollen. It looks so much more normal. It was snappy because you're really removing a lot of the TNF alpha and some of the other evil humors, the bad interleukins. And of course, somebody brought up to me, a very smart person, said, "But you're removing the anti-inflammatory mediators as well." I said, "Absolutely, that is 100% true. Can't argue that. But there's a disproportionality, and you're trying to reset, rebalance a system." And I'm going to talk about that in that talk. But I think those are the kind of things you're talking about.
Yeah.
What the 20% that get past us.
Exactly.
And on that particular day, the 20% didn't get past me.
No, I'm glad.
And I think a lot of people have watched me do this now, and they're starting to see the value in it.
Plus, it's a passion of yours. It's not, see, that 20% would be a 20% to me, but to you, it's in the 80 that you would remember because it's your you love this stuff. I know.
I've
seen you do it, and I know how much you love doing this stuff.
I really do. But I love doing it because I just see it being so incredibly beneficial. I mean, really, at the end of the day, that's what it's about: is am I doing something good here?
Yeah.
We'll talk a lot about this because I think there's just so much controversy unnecessarily about CVVH. But let's go ahead and dive into the first lecture today. Okay, our first lecture today is "Damned if you do, damned if you don't: the clinical and economic paradox of perioperative blood transfusion." Now, I have to say that after all these years, and I come from a time when we gave blood, whole blood, okay? We gave whole blood. There was no such thing as packed cells. We gave whole blood. It's really amazing to me that this is still a topic. I thought pretty much we had all of this under control, but every so often we get these issues of, oh, you're going to get dinged if you give a transfusion. Let's okay, put the blood in the pump, but we're going to document it that we gave it preoperatively.
Oh yeah,
and
that's popular.
Yeah, that's very popular.
Yeah, that's very
and
popular.
So that's part of the problem that I have is that a lot of the data that's used, especially when it comes to retrospective analyses, and I think that's a really key component here, is so incredibly unreliable. And that's part of I think that's part of the paradigm with medical research and medical, when we're making decisions about how we grade something as a 1A recommendation or a 2B recommendation or whatever the case may be.
You need good data, right? I mean, and that's the problem, is the data skewed.
The data is very skewed. Okay, so since it is still a topic, we're going to talk about the topic, and let's have some fun with it if we can along the way. So the core surgical paradox is that the pump, the heart-lung machine, is an unavoidable threat. You have hemodilution, so that you have foreign surface contact area, which is enormous and continuous, and so you have that aspect of it. You have blood-air interfaces with the suctions. Really, at the end of the day, you know, there's people ask me what I do, and I can go back and remember all the real fancy things that I used to say about what it is I do for a living, okay, and try to make it sound as grandiose as I possibly could, right? And but now, you know, at my ripe old age, it's well, I'm a plumber, and every patient that I touch, I am going to do harm to, and every patient that I touch that I'm going to do harm to, my fundamental job is to mitigate the level of harm that I'm going to do to the best of the absolute best of my ability. That's pretty much what I do.
That is what you do.
It's what you do too.
It is what I do.
Right?
I'm still at the stage where I make it sound nicer, though.
Yeah, we facilitate the surgeon being able to repair whatever the problem is.
It's a lesser of evils type of thing.
Correct. Yes. And so understanding that I'm going to harm this patient, what can I do to mitigate the level of harm, right? And so transfusions are as they say here, an iatrogenic threat. You have all kinds of things that can happen. The number one cause of death from blood transfusions is, do you know?
I mean, no.
Infection? Mismatch.
Oh, mismatch. Oh, wow.
Clerical error.
That still happens?
Clerical error is the number one cause of death.
Checking and all that?
Still to this day. Number one cause of death from a transfusion is a clerical error and giving the wrong patient the wrong blood, or the right patient the wrong blood, or the wrong patient the right blood,
and
whatever.
We're talking about this country, right? We're not talking about the whole world, or
no, we're talking about this country,
okay,
the United States.
That's wild. Okay.
And of course, you know, the fundamental belief is that blood is you're going to hear this throughout this lecture, a liquid organ. It is a living thing. Blood is not just well, water's living too. I mean, everything is living. So, but it is an organ, and you have all kinds of things that you have to take into consideration: antibodies, you know, ABO, Rh factor, you know, agglutinins. You have so many NAT testing. You can do nucleic amplification testing, viral transmission, bacterial transmission, especially with platelets, because they're stored warm and it's a liquid for a long period of time. And so it's a great medium for continued growth of a bacteria if there was one introduced at the time of collection. All of these things are concerns, and we have to be cognizant of that. So as far as transfusions are concerned, it is a dose-dependent threat. So if you do not transfuse at all, then you have zero threat, obviously, of having a morbidity associated with the transfusion. 1 unit, you see that it drops down it becomes greater, and 2 units, and then if you have 5+ units, you can see that your time of your percent of survival probability over time is the lowest. So it is in fact dose dependent. I've heard many times, if I'm going to give 1 unit, I may as well give 2.
Yeah.
Okay, we see that a lot with NRP.
Oh, yeah.
If you're going to prime the pump with 1 unit, you may as well prime the pump with 2 for doing the NRP. And in some ways, that actually makes sense.
Sure.
But I think it should be more about what is our target. And we don't do this, okay? I mean, this is a reality. We don't really spend the amount of time that it would take to decide how much red cell volume do I really need to not fall below my minimum threshold hematocrit.
Yes.
And that is something that takes a lot of time to sort of figure out. Right. And we are in an environment where you have to get the case done because you have another case to do. You have to keep going here.
Right.
So our ability to spend the amount of time that would be required to be nearly perfect on every heart operation that we do or NRP case that we do would require more time than can be allowed given the volume of cases that exist.
Right.
And the other things that are downside, because you have downstream effect, right?
Right.
If you have the patient asleep, now your anesthesia time increases, the time in the operating room increases. So it's not just one thing. Everything we do, everything somebody else does, everything somebody outside the room does will affect what happens to all of us.
Right.
And ultimately that patient.
Right.
So keep that in mind that it is a dose-dependent threat. And fundamentally, I believe that if you only need one unit, you should only give one unit. I am definitely not a proponent of transfusing uber liberally.
Sure.
However, I feel that if you allow the hematocrit to get too low, then I think that morbidity is worse than the risk of morbidity associated with the transfusion. Where is that threshold? And I think that also depends. So we'll move forward from here. There is a hidden systemic impact for the blood, the liquid organ. I told you you'd hear that several times. But you will definitely have an immune response, endothelial injury, cerebral autoregulatory dysfunction and risk of stroke, capillary leak syndrome and edema of the lungs. Kidneys, you can develop AKI and requiring new onset dialysis. And it grossly elevates your IL-6 and IL-8 in the postoperative sepsis-like picture that you see, which are, in fact, the immune mediators that pro-inflammatory mediators that I try to capture using CVVH.
Right.
I'll start with TACO, however you want to say it, but transfusion-associated circulatory overload. At the end of the day, this is not going to happen on bypass.
Right.
Okay? You cannot develop TACO on cardiopulmonary bypass. This is more of a pre-op or post-op phenomenon. Okay? And there's reasons why this can happen, not just overfilling the patient intravascularly with the volume of blood, but as you give blood and increase the solids within the blood, you increase the oncotic pull. Therefore, not unlike giving albumin, you give too much blood on a patient who is third spaced, and you all of a sudden, their kidneys are not working that great. You will pull all of this extravascular volume back into the intravascular space. And that's really what the phenomenon of transfusion-associated circulatory overload is. Now, TRALI, on the other hand, transfusion-related acute lung injury, is something that we can develop on bypass anytime you're going to give these patients blood. And you get an immunological storm within the alveolar capillary bed. And it causes quite a disruption, increased permeability. You start leaking into the alveolus. And the next thing you know, you're trying to come off bypass and you have stiff lungs. And, well, what did we do different? Well, you gave transfusions, and a lot of times that's all you did for this phenomenon to occur. So TRALI is a lot more, in my opinion, important to us and a reason to seriously consider whether or not this patient truly needs this blood transfusion. And make no mistake, there are patients that truly need the transfusion.
Yeah.
There's no question about it.
Right.
Okay? But we have to be aware of this.
Right.
And this is also, in my view, mitigatable.
Okay.
Okay, and I'm explaining to you why.
Yeah, your CVVA.
Why
should
I
take care
think
of
that.
it.
Well, there's another way to do it.
Okay.
There's a way easier way
Okay.
to do it, actually. In fact, let me go back to it and we'll just quickly talk about it.
Yeah.
Why do we not? Two things.
Mm-hmm.
One, demand the freshest blood possible, because blood can sit on the shelf for 42 days.
Correct.
You can get 40-day-old blood
Mm-hmm.
for your little old lady cardiac surgery patient who is already pretty sick,
Mm-hmm.
and she's getting CABG, mitral valve repair,
Mm-hmm.
ablation,
Mm-hmm.
and a left atrial appendage clipping.
Oh, Lord have mercy, no.
So we got a lot, and she needs endarterectomies of her
You
coronaries.
scared me. You scared me at repair.
So we're exactly.
Yeah.
So we're going. Me too. So we're going to set this lady up
Uh-huh.
for even more problems after all of this work is being done on her heart.
Mm-hmm.
Why do we not require younger blood for those patients?
Mm-hmm.
Demand it. And two, why don't we wash it in the cell saver? Pediatrics do it.
Yeah.
Why
Pediatrics
do
it.
we not take banked blood, put it through the cell saver,
And
wash it, and then give it to the patient? Would that not help?
It would.
It would get rid of the lysed cells.
Mm-hmm.
It would get rid of the plasma-free hemoglobin that's in there.
Mm-hmm.
It would get, or the hemoglobin that's free floating around in there.
From the lyse cells.
It would likely remove some of the inflammatory mediators, I imagine,
Oh, yeah.
because all you're giving, right?
Yeah, 'cause
It
you
would
wash
take the potassium out.
Right. It'll do that too.
So think about all of the potential benefits,
Mm-hmm.
but yet we don't do it.
Right.
We just take the blood, open it up, spike it, dump it in, and we go on our way. Do it all the time.
We do it all the time.
So should we not be doing this for adults as well? Especially on elective cases where we are doing everything we can to mitigate the deleterious effects of cardiopulmonary bypass on that patient.
I 100% agree. It ideally should be done, especially if you have the time, right? Like now, if you're adding it acutely, you're crashing on, whatever the case, obviously you don't have the time. It's a different story,
Yes.
right? But if you have the time and it's a controlled situation where, you know, you're normally going on and the blood is already in the room and sitting there and they're harvesting a lima, so you got time, like, why
Sure.
not? Right?
Exactly.
You
Especially if
absolutely
you know
should.
you're going to prime with it.
Yeah, especially if you know you're going to prime with it. Exactly. And that decision was made at the beginning. You know?
Right. But
So,
even
yeah.
if you're not,
Yeah.
you know you're gonna, you know your
Yeah.
hemoglobin's gonna be low.
Yeah.
They're like, well, let's just wait and see what the hemoglobin is. Draw the lab sooner
Yeah.
and just have it ready.
Yeah.
Because what's it gonna take? 5 minutes?
Yeah. No. Yeah. It's exactly
5 minutes.
Yeah. Not long.
Not a whole lot of time,
Mhm.
right? On the other hand, as you see here with TACO, it's really a hydrostatic force. You basically overfill and it pushes the volume out. So, I mean, we all know what heart failure looks like, and that's essentially what you're doing is you're creating heart failure by rapidly transfusing somebody and overfilling their vascular space. So what are the differentiating mimics here? So the pathophysiology in Trally is non-cardiogenic permeability, so it's not heart failure.
Mhm.
Like is TACO. So you can
Like
see
TACO,
here, this is cardiogenic. You're basically going into heart failure.
Mhm.
This is non-cardiogenic. This is basically inflammatory mediated inflammatory storm. Primary patient risk: critically ill, plasma-rich product exposure, elderly, renal, cardiac dysfunction, positive fluid balance. We talked about that already. Clinical presentation: hypotension, transient leukopenia, thank you,
Yep.
and fever. Hypertension, elevated BNP, which is your brain natriuretic peptide, and abnormal echocardiogram. So again, heart failure.
Right.
Cessation of the transfusion, well, you can't do that on pump because you've already dumped it all in there.
Yeah.
And not giving that patient diuretics if they're not on bypass. On bypass, it's not going to make a difference. Diuretics, fluid restriction, upright positioning, because you're trying to empty the heart out so that so put them in reverse Trendelenburg to reduce the volume in the heart. So we've all done these maneuvers many times. You're off pump and you want to fill the heart up, and the heart already looks a little full. They put them in reverse Trendelenburg. Heart empties out, and you can fill them up a little bit more. So there's a 2-hit pathophysiology of TRALI. The hit 1 is vulnerability. You have a pre-existing clinical condition, surgery, systemic inflammatory process taking place, primes with neutrophils in the pulmonary endothelium. So you're basically creating an environment. In hit 2, the catalyst, donor anti-leukocyte antibodies or biological active lipids activate the prime neutrophils that have already migrated into the pulmonary endothelium, and then you get an endothelial damage, capillary leak, and acute non-cardiogenic pulmonary edema. And so that's those stiff lungs that aren't making any sense. You're on bypass, the heart is completely empty, but these lungs are stiff. What is the reason TACO is not important? The reason, let's see. 3, exciting. I will be joining Samir Patel. The program is always fun. Okay. Sir, why am I unable? Okay. What is the reason for TACO not being important concern while on bypass? The reason is longer time developed in comparison to TRALI. No, that's not the reason. The reason for that TACO not being a concern on bypass is because your heart is completely empty. Your heart is empty, so there's no reason to be concerned about that. You have an open reservoir, so your venous reservoir volume will go up if you pull a bunch of fluid in from the extravascular space. But you can transfuse as much as you want into the pump because the heart continues to remain empty. TACO is a problem in a closed system, not on bypass, when your heart essentially blows up and you go into hypervolemic heart failure. So that's the difference fundamentally. And then there's an economic burden. And, I'll talk about the economics here. There's so many varied costs, and it depends on what organization you're talking about. And blood and transfusions have born so many different organizations, SABM and, the AABB and the this and that. There's so many different things. People have published books. People have done programs where, hospitals were developing transfusion management systems, and there were some perfusionists. God, I wish I could remember his name. There was a guy. He was crazy as a bedbug. What was his name? I may remember it later, but he would go around and give lectures on, on transfusion management departments within hospitals, and all of the, I have the power to say whether they get transfused or not. And it was so, I can't remember his name, but he was just such a goofball. I found it fascinating that there were a lot of hospitals that actually did do this. And they had transfusion management committees to make decisions about blood, and would be in the operating room, and it's like, just give the blood. I mean, are you kidding me here? I'm not doing this, and so it sort of became almost a joke. But some of them had some real power and did some really stupid stuff. In fact, that same guy had advocated for having your hemoglobin below, not transfusing until your hemoglobin was below 5.
Oh God.
And yeah.
That's real low.
Yeah, I think it's insane.
I think anything below 7 is insane.
But
5 is like, oh my God.
Yeah. Yes, absolutely. And 7 can be. It depends on the patient.
You can make a case for it.
It depends on the patient.
It depends on the patient.
Here's the problem. We're going to talk about that when I get through with this lecture. Anyway, costs range from $522. This is one hell of a range, to $11,000 per unit. So, that's kind of a pretty broad range. And I think that in many ways, I think that it discredits this idea. Can a major morbidity associated with giving somebody a transfusion result in a really increased hospital cost? Well, of course it can. And the number of patients that experience a truly major morbidity or mortality is extraordinarily low. It is not just everybody I give a transfusion to is having these things. Now, they all risk increased inflammatory processes. I mean, I think that's pretty much universal to everyone. But there is this biochemical reaction, and then there's this clinical relevance to that. And so for it to be truly clinically relevant, it really did make a difference in this particular patient. That's extraordinarily low. And to say that it just happens all of the time and it has deleterious effect on the patients, I think is disingenuous at best. However, you can certainly have very increased cost. The acquisition cost of blood, the cost of buying it, the hospital has to buy it in order to give to the patient, is probably somewhere between $500 and $700. It's about that range. It's in that range. And that's because of all of the testing that needs to be done, because people donate the blood.
Yeah.
But you have to, there's a lot of processes that go forth once blood is accepted to be donated from someone. There's testing of the donors, making sure they don't, have anything, and before it goes into the pipeline.
I agree with that part, but like this slide to me, it's too way out there. You know what I mean? Like
it is,
what's the cost of not giving the blood when you need the blood?
Yes.
You know what I mean? Like what if they need it? Let's say there's a 5 and the patient needs to be at a 7.
Yes.
And then you don't give it. And now you've increased the ICU stay another 2 months post-operatively or whatever the case may be. What's the cost of that?
Yes.
So, I mean, it depends, I guess, on how you're looking at it. You know
right.
what I mean? Like,
well, right. But if you're an industry, if you have created a business of selling your transfusion management system,
okay,
you're only going to look at it one way.
Oh, well, yes, because you're biased, right?
And right. And so these people, they drive articles into the journals to try and force it to be a standard.
Yeah.
And this is another one of our paradigms that we deal with in medicine, is how do you filter all of the data that is out there that we learn from credible to non-credible information. And that is supposed to be the job of the publishers.
Correct.
Okay.
Yeah. Which
and the editors.
Yeah, which obviously doesn't happen.
Correct, because you have credible journals and you have not so credible journals.
Which you did cover in one of your one of our
Yes,
podcasts.
I did.
You've had a PerfWeb about that.
Yes, and I'm probably gonna I'm
gonna have it again. I'm sure.
And I'm probably gonna bring that up in one of my later talks. Exactly. So, resolving the paradox, and this is the TRIX-3 trial. Does the risk of anemia outweigh the toxicity of transfusion? And this is data from 5,243 adult cardiac patients. So if you look at the restrictive strategy, this really wasn't a great paper. This wasn't really a great trial, but it gave us at least some insight, okay? Because sometimes if you're transfusing, there's a reason that you're transfusing, there's something else wrong, and those things never seem to be factored into these studies. So you have to take that into consideration. They don't do a great job at case matching or subject matching in regards to their analyses.
Yeah.
But with that said, With the restrictive strategy, not giving transfusions until it's less than 7.5, your hemoglobin is less than 7.5, 52.3% of those patients were transfused. If the hemoglobin fell below 9.5, 72.6 of those patients were transfused. So I don't really view 7.5. That's something they did good in this actual trial, so I'll take that. I'll give them credit for that. Is they didn't use some ridiculous number like 6, hemoglobin of 6 for transfusion, or even 7. They did 7.5.
Yeah, I like
so
that.
in if you go back just 10 years, this was considered
the trigger point.
the liberal, the restrict. This restrictive was considered liberal.
Yeah.
Okay.
Yeah.
So I'm seeing a shift more towards giving transfusions more frequently. But anyway, with that said, there was essentially no difference in mortality, strokes, rates of MI, or AKI. Essentially no difference. So then the question becomes, did this patient, how many of these patients really needed the transfusion?
I mean, I find that to be
and how many of these patients really didn't need the transfusion? And you cannot, you go through this if you'd like to, you can look it up. I cannot discern that from this. But it doesn't have time to extubation, another one of our metrics. It doesn't have length of stay in the ICU. It doesn't have length of stay in the hospital. It doesn't have how did the patient feel? What was the time before they returned to normal activities? All of these other factors involved. So from this study, based on just this one slide, I take away from this that giving the blood to patients was not deleterious.
Yeah.
Okay.
Yeah.
This is what I take from it, because I do believe there are patients who need a hemoglobin of 10.
Okay.
I think if you're a 67-year-old female with a body surface area of 1.7, and who is having a mitral valve, aortic valve, double valve cabbage procedure, and you and coronaries, and you have some level of ventricular dysfunction, which could just be from the valvular dysfunction, but nevertheless it's dysfunctional. My view is that patient will do infinitely better with a much higher hematocrit than with a lower hematocrit. Infinitely better. And that's just clinical observation. That's my 2 eyes looking at how many of these cases have I done and who's done better and who's not done as well.
I mean, it all comes down to DO2, right? If you don't have the forward flow or enough forward flow, you better have the crit.
And viscosity.
And viscosity.
The heart doesn't have to beat as hard, because you're going to still have, autonomic systems. So your heart is going to react to the anemia by beating more. And faster. And so it's just, you just sort of have to look at this from the milieu and not from one little piece. And I think that's something that also gets mixed. We look at the evolving guidelines, and it is definitely evolving. The STS, the SCA, AMSEC, the AABP mandate a shift towards comprehensive blood conservation. I think blood conservation as a concept is a bad idea, because it sounds like you're going to withhold something from someone. I would prefer comprehensive blood transfusion management, which is what they sold as a service, even though I think it's, lack of a more eloquent term, bullshit. I think that it can have value. I just think it was grossly misused. But you want to look and see who are your patients that are going to be at risk, who is going to benefit most from either not having a transfusion or being transfused early as necessary. This says to mandate a restrictive transfusion trigger of less than 7.5. I disagree with that entirely. I think that should be your transfusion trigger should be individual patient dependent. I take you, I'm going to have no problem with your hemoglobin being 7. None. I would fight tooth and nail to not give you a transfusion. You're an otherwise healthy young man.
Sure.
You should do well.
Yeah.
Again, the lady that I talked about, the patient,
Not so much, yeah.
I am going to argue tooth and nail to not let her hemoglobin be below 10 coming off bypass.
Yeah, right.
Okay. She may have so much excess fluid volume that I can get her hemoglobin to 10.
Sure.
And you don't want to overstuff that heart.
No. Right.
So I should have plenty of blood in the pump. So aggressive ultrafiltration makes sense to me.
Yep.
And of course, that doesn't get brought up in any of this
No.
if you're on bypass. So there are ways to increase the hematocrit or the hemoglobin without transfusing, because if you come off bypass and you still have 1.5 liters in your reservoir, that means, and your system holds 700, you have nearly 2 liters that are going to go to the cell saver. You'll get the red cells back, but not the blood. All of that should have been removed during the procedure. You should come off bypass with just enough volume to fill the heart with no blood left in your reservoir, and then flush what you have in your line so the patient gets all of their blood back. From the pump, you should not have any, you should only have enough blood remaining to completely fill an already almost full cell saver bowl. It's only just to get the last little bit that you need, not to process 4 or 5 units of cell saver and then give it back to the patient. That's my belief. And then a comprehensive multidisciplinary health system-wide clinical community approach. Yes, I agree with that. I think that there should be stakeholders in this, and I think we should develop better protocols to figure out how should we be transfusing, who should we be transfusing, who we should try really hard not to transfuse, all of those things. I try not to transfuse anyone, but you can't just have that as your dictate. I'm not going to transfuse anyone. It's a bad idea.
No.
Very bad idea.
No.
Optimize erythropoiesis if you have the time and you can give these patients EPO before they come in. That'd be great. Unrealistic here in the United States because of the way we do surgery. You come in, you have a problem, we're going to operate on you today or tomorrow, maybe the next day. It's rarely, or maybe the next week. It's rarely ever long enough for erythropoietin injections or whatever to get your hemoglobin up. Minimize blood loss. Of course, you cannot underestimate the value, the benefit of good surgical hemostasis. Obviously, that really, really matters. We see that at NRP a lot. Makes those cases just miserable when they don't follow that idea of just creating a good hemostasis environment.
I've recently had a case where it was just they did such a bad job at hemostasis, and I was just losing volume everywhere. It seemed like it was coming out of the ears. Obviously, it wasn't, but it seemed like it.
I understand that. And then pillar 3 is harness the physiological tolerance. And you know, again, you have a patient who's young, otherwise healthy, really doesn't have any severe cardiac dysfunction, should be able to tolerate a lower hematocrit. If you can get away with it, I would try to get away with it when possible on those patients. There are patients where we probably should not be transfusing. We should not transfuse a number. We need to transfuse the need.
You got a question?
Oh, a question?
Yep.
Consider hemoglobin levels. Let me see here.
Should we consider hemoglobin levels?
Okay, sir. Then should we consider the hemoglobin level or CaO2 could be good alternative to prevent unnecessary transfusion in patients just relying on hemoglobin, despite knowing that hemoglobin is most important index? Well, sure. I mean, I agree with that 100%. If you have a good DO2, but you have to remember, you're on pump. You have a mechanical pump. You can increase the flow mechanically. Whereas if you come off bypass with a low hematocrit, low hemoglobin, then the heart is going to have to do that now. So are you setting them up for a simplified unremarkable postoperative course are you setting them up for a rocky postoperative course?
Kinda
So
like you just mentioned with the autonomics and the low hemoglobin.
correct.
And yeah.
So I'm definitely supportive of measuring the DO2I. You should measure your DO2 index on bypass. But of course, the best way I think to deal with it is to say, okay, I've got to have a cardiac output here of 6 liters, 5.5 liters on pump to have a DO2. First of all, that's really hard to even do on bypass and keep the heart empty.
Yeah, that's terrible.
So, if you want to do that, but there's going to be a postoperative period. So, yes, I agree with you, Aksh. I do think we should measure both the hemoglobin and the CaO2, which so what you said makes sense.
Yeah.
Here's the PBM, patient blood management execution, intraoperative blood conservation. And I've got this piece up here for those of us who may not remember. Class 1 is that strong. The benefits far outweigh the risks. The treatment should be performed because it is proven to be useful and effective for nearly all patients. Class 2A is moderate. There's moderate benefit to risk, and it's reasonable to perform the treatment. Most experts agree it is effective, though more data might be needed. The Class 2B is weak. The benefit is equal to or maybe greater, so it could be considered. And then Class 3 is no benefit or harm, in which case you should not do it. So that's the classifications for benefit as you look at these things. And intraoperative blood salvage, as one would expect, is a Class 1 level A. I completely agree with that. Modified ultrafiltration is a Class 2B. I disagree with this entirely. And of course, there's a big difference between modified ultrafiltration and cuff and Z-buff, and we're going to talk about that a little bit going on. Reduced priming volumes and retrograde autologous priming is also I believe it's a 1A. It could be a 2A or 2B. I'm not really sure. I don't remember. But I completely I agree with reducing the priming volumes. Our circuits are way too large, should be smaller, including mine. But I completely disagree with RAP. I think that this has higher risk than what the benefit will be. So those are my concerns with that. But we could talk about that on another day. And then the legacy was treat the laboratory number, reactive transfusion of donor products, and the result of that was high cost and systemic toxicity. The new paradigm or modern paradigm goal is treat the patient holistically. In other words, we should look at each individual patient, make decisions about transfusions, proactive preservation of the patient's own liquid organ via patient blood management. That's good hemostasis, not over phlebotomizing these patients, all of those things. I say this all the time, every cc of blood, extra blood that you remove is another cc not in my reservoir. And if you're running a reservoir at minimums because you don't want to give this patient any more volume, you don't want to transfuse them, and you're just, right at what is your limit, every cc extra in a tubing, every cc extra that you take for blood sample analyses is one more cc above my level sensor. And so I really try hard to, if I'm going to run a blood gas and I only need a half a cc, I take a half a cc. I hate it when anesthesia hands me a 5 cc syringe full of blood for an ACT and blood gas when I only need a half a cc.
Yeah, they do that a lot too.
So I, generally will take that and squirt all 4.5 cc's into the cell saver and then go and run my samples. So that, it just makes sense.
Yeah, that makes sense.
And so we are not damned if we adhere to strict patient blood management, reduces long-term mortality and morbidity, eliminates the twin threats of Trally and Taco, really not on bypass applicable, but The trolley certainly is, and it can save a lot of money in healthcare costs, with the caveat that not giving blood can also increase healthcare costs. So let's please try and do this the right way. The future of cardiac surgery lies in preserving the patient's own blood. And here are my references. And I believe I am done with that. Comments, concerns, questions? What are your thoughts?
I mean, I think you covered it pretty well. I kind of told you my thoughts as we went along. But I find it's now becoming too fine of a line, you know what I mean? Because so many people are trying to, like you say, adhere to rules where they say, oh, no, we don't want to give blood. And they've come to that determination preoperatively, you know, before even experiencing what we're about to experience over the course of the next 4 hours. You know what I mean? I feel those cases become the most dangerous. Specifically, you have to be open-minded to audible, right? Like this is surgery, man. Like you don't know what's going to happen over the course of the next 4 hours.
No.
We've all had easy surgeries that went awry. We've had hard surgeries that were easy. Like, you know what I mean? Like it can go either way.
Yes.
You never know what's about to happen over the course of the next 4 to 5 hours, or possibly more. So I feel that our decision making needs to be fluid with that type of atmosphere. You know, you can't just we have surgeons that we work with that are gung ho about certain things, and that's okay. They're allowed to be. They've been doing this a long time. Most of the people we work with, but you know, I always feel that like I've said this multiple times before that you know each patient is different. You never know what to expect until you're experiencing it. So
Yes.
your decision making should be the same exact way.
Exactly. And I want to talk about DO2.
Okay, now let's talk about the
I
other.
want to throw that out at you because you just had a situation that that I think was appropriate for this conversation.
Yes.
And it goes to Aksha's thoughts. We talk about a threshold of 280 to 300, depending on which study you look at. Some are even 320 now, right?
Yeah.
And even that's low.
Oh yeah.
A DO2I of 320 for you we would not feel well.
No, we
right?
wouldn't feel well.
But we're
That's
not
terrible.
under general anesthesia
No, yeah.
and cool and you know all that kind of stuff.
Yeah.
So paralyzed.
Exactly.
So you know there is that element that
There's
I think
things
he
that
would,
bring a normal level down.
Correct.
And make 300 okay.
Yes,
Yeah.
exactly. But with that said, we talked about the little old lady, the little 70-kilo little lady, but what about
the opposite?
The
Like
opposite.
my patient?
yes,
Yeah.
when you have a
The
patient
2.6 BSA person?
Yes.
Yeah.
who what actual cardiac output does that patient need
Yeah.
to deliver an appropriate DO2?
Yeah. I mean, ideally, you remember I called you before that case.
Yes.
And I told you I was never going to flow what the mathematics indicate because that patient was just a lot of fat. I felt that the patient was still large enough that the ideal body weight didn't seem like enough.
You
either.
can't say that there was a lot of fat.
Okay.
You have to say it differently.
Let's be grammatically correct.
They were robust.
They were robust. A little on the chunky side.
Fluffy.
Fluffy. I like the fluffy one. But the bottom line is they had size. And I did obviously we're all taught in perfusion that, okay, ideal body weight, morbidly obese, ideal body weight. You're taught these two words go together, you know? But even my ideal body weight, I'm never a fan of using the ideal body weight. I personally like using adjusted body weight, which is almost falls in between the two. It falls between ideal and real weight. I've always been a fan of adjusted, and I try to flow what the adjusted is, which is somewhere in the middle. And that was exactly what you had told me. You just didn't use the all terms. You're like, take the ideal, take the real, and go somewhere in between. I was like, so you mean the adjusted? I'm like, that's where I'm gonna go, Joe.
Yes.
So yeah, I mean, obviously, it's hard to calculate what actual DO2 you need when they are that big. You know what I mean? For me, that case, oh my God, that case was crazy. That was the case that I was alluding to where I had blood coming out of everywhere, people. It was a really crazy case. The chest team did not do a good job of of closing all that they opened up. They didn't do a good job of clamping what they needed to clamp, and boving off azyguses and this and azyguses or whatever, however you want to say it. But bottom line is, yeah, we were coming losing volume out of everything. So that beautiful conversation that me and you ended up having at the beginning of that case didn't matter anyway, because I never got even close to flowing what I needed to flow. Anyway, beautiful. I just didn't have volume. Obviously, in perfusion, to flow, you need volume.
Yes.
There. So
Yes.
yeah, that case, I would have been loved to be near the adjusted. I was lucky to be near the ideal. I was like,
Yeah, exactly. And I think it's just, these are realities,
this is realities. Yeah.
you know, realities.
Yeah.
And sometimes it's where the cannulas are.
Yeah.
And, and everybody's, in their, in their particular bubble.
Yeah.
Everybody's in their own silo.
Yeah.
Going, I put the cannula in the right spot, it's working. Well, can you just pull it back some?
Yeah.
And that can be very treacherous if you're using a Babcock clamp and they don't know how to do purse strings. And even in cardiac surgery,
That's
the
when you have 'em
surgeons
come flying out.
the surgeons are complaining about whatever they're complaining about. I didn't put it in too deep. You did. It's in the liver. Pull it back. It's going to be in the atrium if I do. No, it won't. Please pull it back.
Yeah.
And all of a sudden everything gets better. And I'm like, there you go. And they're like, well, I didn't do anything. And you saw them move it.
Yeah, you saw it.
I saw you.
That's just, they're not ever going to admit to that, right?
No, clearly not. Clearly not.
Perfusion's never right, Joe. I don't have to tell you that. You've been in this 40 plus years. I'm sure you learned this by year 2. Perfusion's never right.
No, correct. But anesthesia is always wrong.
Oh, always wrong, yeah.
I think we can, so Ox says, I think we can judge that the perfusion parameters are good, if they're good or not, using O2, the O2 extraction rate or DO2 VO2 ratio. Correct me. No, you're not wrong.
No, yeah, you're right.
For those obese patients. Yes, you are correct. I think you do need to look at everything, and doing an SVO2 for a case like that is a good idea. It'll give you a lot of good information. Yeah. Running lactates is a good idea. So yes, there's a whole bunch of things that we can do and probably should do that we don't do normally. Yeah. Now, I will admit, and you all can criticize me if you want to, right. I don't care, but I've run this test many times. I've won so many bets that I'm rich if people would just pay their bets. Right. And I've said, what do you think that SVO2 is? What do you think that venous saturation is, looking at the venous line? And I'm never off by more than 2.
Yeah, that's because your eyes
I can tell you what that SVO2 is. Yeah. Yeah.
I believe that.
Yeah.
Because 40 plus years. He's been doing it a long time, people. He's pretty old.
Yeah. I'm very old.
Yeah.
Okay. Well, that was a fun topic.
That was.
Okay, to get us started for the day. So can we take a 5-minute break? Yeah, 5 minutes. So we're going to take a 5-minute break. I'm going to get another coffee and maybe use the restroom, and then I will be back to talk about NRP, NRP and bridging the organ availability gap. That's going to be our next lecture. Okay, and welcome back. Welcome back, everyone. What the hell happened?
I don't know.
I looked over there. I thought you were wearing sunglasses for a second.
No.
Okay, so we're gonna go ahead
I
and
do got them raccoon eyes going right now, though.
uh-huh.
I've been sleeping a lot lately, Joe. You know that.
Have you?
Yeah.
That's what's wrong.
Yeah, that's what's
You've been
wrong.
working a lot.
I have been.
Actually, you've been working a lot. You are. Yeah. Samir is going to be heading back to India
I am.
for a couple of weeks,
I am.
and
Excited about that.
he is doing every extra case that he can
can.
possibly do because he doesn't want to fly coach
I don't.
across the big expanse of ocean. He wants to be able to lay back and enjoy himself. So you
And
are
my
going
time there too. I plan to like really relax
and have fun.
and have fun because last time I was there, I was living there. I wasn't like this, you know. I wasn't like a visitor that's just there to have fun and do nothing.
Right.
And so yeah, I want to.
Yeah, the last time we were there, we were working.
Exactly. And it
Right.
was COVID. It was
Ooh,
a terrible time,
Dude, I know we
It was a
probably
terrible time.
we should probably do you should probably do a program on my experience with COVID, my experience
I
with
would love
COVID
to.
in
I
India
would love to.
because
It
we
was so
have
different.
yeah, I would love that.
Yeah,
I
let's
mean, I
do that.
think that would set that up.
Yeah, let's do that. Let's do that.
I mean, we need to do that. Okay, I'll set that up
Yeah,
for
yeah,
the next
yeah.
one. Okay,
Great one.
getting started here. Welcome back, everyone. I will go forward with NRP and bridging the organ availability gap. We've talked about this before. The issue is that the number of patients on the wait list for organs does this, but the available donors have remained somewhat static. And standard SRR, or that just means super rapid recovery. So, when you do DCD, let's just go backwards. When you do donation after brain death, the physiologic organs, the heart, the lungs, the liver, the kidneys, they're all working. And it's the patient's brain dead, but everything else is working. So you can take that patient to the operating room in a controlled manner and take your time.
Oh, those are so much more fun.
And
I
yeah.
got to be in one. Obviously, we had our ECMO patient,
Yes.
the DBD, and then I got to be there in the operating room and experience a DBD with the same team that we usually work our
Yes.
DCDs with. So it was nice. So because I already knew everybody, but man, it's a different experience, Joe.
Yes, it's very, very controlled.
Yeah, very
and
slow. They're joking. They're laughing.
Yeah.
It's not like the first 10 minutes of an NRP run or a DCD.
Yeah, and that's not to say, just for reference. I mean,
Yeah.
we do have. I mean, we deal in death a lot,
We do.
and it is difficult for us enough. So I think just for reference to the people that may be watching, it's a more relaxed atmosphere.
Yeah, I think that's what I
and
mean. I don't mean no. People aren't
Yeah.
joking around in a bad way. It's just, I should say it's a lighter-hearted mood.
It is.
Maybe I should say it that
Yes,
way.
even though we are sad at the
We're
person's
very sad,
demise,
Yeah.
we know we're going to be helping all these other
Exactly.
people. And I think that's an important distinction to make.
There is.
Nothing wrong with what you said.
No,
I
yeah.
get it. I'm in this industry too.
Yeah.
And so, for those of you, those that might be watching, do understand that we do take this
Like I
stuff.
told you, I think I've become immune to death. Remember I was telling you
Yes.
literally right before we started this program.
Yeah, it's true.
I've worked in stroke for 8 years. Trust me, I've been around death a lot in my life, sadly, but
Mhm.
I have.
It's a reality.
It's a reality.
And if we let it all affect us, we would be complete wrecks.
Correct.
So we have to filter it. We
And I did
have
let it
to-
affect me the first year, and I
Yeah.
had to learn. You have to learn how
Yes.
not to let it affect
Yes.
you. It's a skill that's learned.
Yes. Well, we have protection mechanisms for
Right.
ourselves, or we would be, like I said, emotional disasters. We couldn't
Exactly.
function.
Yep.
But with that said, you take that patient, and it's a very controlled environment for brain dead. They open them up, they get everything ready. The various different teams, heart, liver, kidneys, whoever's there to take whatever organs, essentially coordinates with each other. And then once the heart gets clamped, everybody else does their thing. That's of control. They flush the organs, take them, put them in the cooler, and send them on their way. In DCD, donation after cardiac death or circulatory death, that's a completely different paradigm. That patient could be taken to the operating room or could be taken to the recovery room, depending on several factors. But at that point, life support is withdrawn from those patients, and you wait until they have asystole or PEA is acceptable. But mostly it's going to be asystole.
In fact, they're getting away from PEA nowadays.
Yes.
Yeah, they're wanting to accept it less and less.
Yes, and we're going to talk about that as a matter of fact. Thank you.
Yeah.
But so your warm ischemic time can be relatively short, but it can also be relatively long. It can be an hour, and it could be up to 2 hours in some circumstances where the blood pressure is low, their saturation is low, but their heart is continuing to function. And so you find yourself in a situation. Hey, Magic, I'm sorry. Can you do me a favor, please? Can you please call Dr. Nieto back for me here? And just tell him I'm in the program. Find out what he needs, please. I'm so sorry. Please forgive me, everybody. But with that said, once the heart does stop, then you rush that patient into the operating room. There's a 5-minute standoff period where you can't touch them. Then you have to open them and get them cannulated or take the organs is the case. So in SRR, super rapid recovery, you wouldn't put them on NRP. So you have all of that warm ischemic time, and now you open them up, flush the organs, take them out, put them in ice, and send them on their way. And in those particular circumstances, you never have an opportunity to really restore all of the things that have occurred during the death process, including reactive oxygen species, severe acidosis, ATP depletion, lactate accumulation, all of these things that have taken place in the cellular structure of any individual organ persists, and you never do reverse that. All you're doing is just recovering the organ and sending it as is. And that has not proven to be very good. So NRP is used to restore or to reverse the warm ischemic period and get the organ working again, functioning normally, so that you can then assess it, and then you take it for transplantation, for storage and transplantation. So that's the difference between those two. NRP is a mechanically assisted regional perfusion technique that temporarily establishes oxygenated blood flow following the declaration of death. And some of the things that we'll just go through the process, but it restores depleted energy substrates, as in adenosine triphosphate or ATP, clears detrimental byproducts of anaerobic metabolism vis-a-vis, everything was okay? Thank you. Vis-a-vis, you're reducing your lactates, clearing that, and various other things. Transforms a hurried super rapid recovery procurement into a controlled, unhurried surgical process, and enables real-time in situ assessment, meaning inside the body, assessment of organ viability. One of the things that's critically important is the isolation of the brain. You have to assure that you are not going to reperfuse the brain, albeit I think this is somewhat of it's an ethical dilemma, somewhat of a red herring in my opinion, because after the length of time of warm ischemia, the 5 minutes of no touch, the 5 minutes it takes to get in there, cannulate and get on NRP is 10 minutes. I cannot begin to imagine a circumstance where that brain is ever going to be functional in any capacity, even if it were perfused. But nevertheless, for the sake of absolute certainty, it is critically important to isolate the brain from these circumstances. And here's your basic NRP circuit. This would be thoracic cannulation. You can cannulate abdominally, or you can cannulate thoracically. And we'll talk about that as we go on. Here is abdominal NRP. It's usually femoral cannulation, or you can have femoral venous that's placed way up high into the heart as best you can, and then you have your arterial either in the at the bifurcation of the iliac and the aorta, or just in the iliac itself. This is generally used for abdominal organs. You have to make sure that this is a coda balloon, but this sometimes does and does not work well. But clamping it is obviously better. Clamping it and venting it, we're going to talk a little bit more about that to assure. But if you're going to occlude it, you have to occlude it supraciliac, because if you're below the celiac, obviously you're going to have a problem there. So you have to make sure that you are supraciliac with your occlusion device or your clamp. And in thoracic or thoracoabdominal, you can cannulate up here in the chest, and you can perfuse everything, and you see your clamps on the innominate and the left carotid subclavian over here. But you can perfuse the heart and all of the abdominal organs through thoracic NRP. So the chronology and ethical milestones that have taken place here, you have withdrawal of life support therapy. It's sometimes referred to as WLST, but we call it WOLST, WOLST. It's a little easier to say than WOLST. And the agonal phase, this can take up to 2 hours. Some hospitals, and it's hospital dependent, some hospitals require no greater than 90 minutes. So from the time of withdrawal, if they do not pass circulatorily, within that 90 minutes, you're done. Some are 2 hours. It just depends. Once you have a systole and a declaration of death, there is a mandatory standoff, which is strict 2 to 5 minutes. Currently, I understand it to be 5 minutes, though I know there is a big push to reduce that to 2 minutes. And this is where you cannot touch the patient, ensuring irreversibility of circulatory cessation, meaning the heart does not auto-resuscitate. But this period of time is also resulting in severe anoxic brain injury. Right. So, clearly you're, not only anoxic, but no flow.
Right.
It's complete. Yep. So clinical, ethical safeguard, the standoff period independently confirms death prior to any surgical intervention. It's very interesting, but in Italy, their standoff period, this period, is 20 minutes. Yeah, 20 minutes.
And they still have good outcomes.
They have great outcomes.
Yeah, that's crazy.
They have great outcomes. It's really amazing. It's pasta and a lot of walking.
That makes me really think about what we rationalize as warm ischemic times. You know what I mean?
Yes. See, red wine is good for you.
Yeah, apparently.
Italian red wine. Yeah, and then you have, exactly, then you have cannolis. Then you have incision and cannulation and neurologic isolation, clamping as we discussed in the previous slide, and perfusion initiation maintained for 1 to 4 hours at 37 degrees for assessment of the organs. I would say
4 hours?
It can be up to 4 hours. It can be. Hearts.
Okay, yeah, that's fair. They do, yeah.
Yeah.
Especially if because it takes that long, yeah.
You can, especially if they're really looking at it and wanting to load it and assess it and do echoes and everything else. So normally it doesn't take that long, but it can. Normally it can. There are cases where it actually does go that long.
Okay.
Here is the methodology for neurologic isolation, the absolute barrier. You have, this would be, of course, not to scale clearly, but this would be your celiac. This is superceliac. And you can see here opened to atmosphere. The same thing here with the arch vessels. You have the innominate, which is getting your right carotid and your left carotid and your subclavian here. And it is optimal to vent it to atmosphere to make sure that it is, in fact, you just put a nick in it, put a hole in it, hole in it, hole in it, to make sure that you don't have any flow coming from somewhere else going up to the brain.
They're starting to transect them now too, right? Clamp and transect, if I'm
Yeah,
not
you
mistaken.
can.
Yeah, okay.
Yes, you can.
Like that's like the newer thing they're doing now.
Yes. And I don't have a problem with that. Just make sure you have a good clamp on it.
Yeah.
Right?
That's
If you have a
fine.
good clamp on it, there shouldn't be a problem.
Yeah, obviously. Yeah.
And this is something that I think to their in their defense, the surgeons I'm referring to, it is chaotic.
It is.
Because this, the time is ticking. That
Yeah.
warm ischemic time can have, although not in their defense, I think going slower would give us better outcomes. But our grading system here on their efficiency,
Yeah.
they're graded on time from
Incisions,
death determination to initiation of NRP is a time that people look at.
They do. And they'll ask you that time regularly. The
Yes.
surgeons, how long before we were on NRP? How long before we were
Right.
on NRP? It's
Where-
their measure for how good they did, you know?
Right, and I think that's a disservice.
Mhm.
I frankly think that taking another minute or two would result in better cannulation, less bleeding in the operative field, and I think a better NRP run.
I
So,
agree.
but of course, I'm not the one who decides how they're judged. So
You're
that's the
not.
way that works.
Or you're the one being judged.
Exactly. And it's very important that people in the room, you can see it here, that we verbally confirm you have isolated the cerebral circulation. That's probably the best way to say it. So circulatory death remains permanent in the brain, strictly adhering to the Uniform Determination of Death Act, UDDA. I had never heard of that before, but I know what the dead donor rule is, but I didn't know there was a Uniform Determination of Death Act.
Wow, that
I did
sounds-
not know that.
that
This
sounds
is very-
really official.
Yeah, it does. This is very regulated.
Yeah.
You know, I
Oh,
don't
no,
think
yeah.
people really understand just how regulated
Oh
this
no!
this
I mean,
industry
we're constantly
actually
getting
is.
emails about this. Like even recently, that we have to make sure that we call it. If they don't call it out that they clamped it, then we need to make sure that we audibilize.
Yes.
Is it clamped?
Yes.
You know what I mean? Like
Mhm.
have
Mhm.
our head vessels is descending aorta, something. Wherever is
Yes.
going to feed the brain, is that clamped?
Yes.
Depending on where we're cannulating.
I would probably just say, has the cerebral circulation been isolated?
I like that. I like that
that's-
word verbiage.
Very
It
precise.
is very precise.
Clinical outcome dashboard. So let's take a look at what these results are, because at the end of the day, it's like anything that we do. And I said this earlier, the cardiopulmonary bypass circuit and the NRP circuit and an ECMO circuit are nothing more than plumbing circuits.
It's true.
It's taking fluid and moving it from here to there. That's it.
Yep.
Okay.
They just
So-
all go through different stuff.
Correct.
Yeah.
Right. And you have to understand the anatomy
Mm-hmm.
of the plumbing, the piping
Right.
that you're working with.
Exactly. Yeah.
And that's, of course, what we're trained to do.
Trained to do,
We
right.
we don't need to see the plumbing. We know what's going on inside there because we understand and know the anatomy. We are looking at a body, but we literally can see into where the blood vessels are and understand
So
all
what
of
you're
these
saying is
circuits.
We're plumbers.
We're plumbers. That's all I'm saying.
We've come full circle.
Full circle. Full circle. So, ischemic type biliary lesions is your most significant issue when it comes to early graft loss. Excuse me, of the liver. from DCD, donation after circulatory cardiac death. You have significantly lower rates of primary non-function and early allograft dysfunction compared to static cold storage. So with NRP, you can see you have a gross reduction, a very good reduction in these ischemic type biliary lesions. And then utilization rate is up to 90% with NRP in situ selection, macroscopic aspect, color, congestion. So we see the organ, because it's dead when we open it, but then when we get on NRP, it's gray and it just looks dead. Doesn't look good. Has no blood flow going through it. And when we put it on NRP and we start perfusing it again, we see it become much more normal in color and in texture, and they can truly assess the organ by looking at it with it actually being perfused, and it makes an enormous difference in being able to assess these organs. So you have a macroscopic aspect, you have falling lactate clearances, which we look at, and you have transaminase or ALT levels monitored. We don't monitor this. We measure lactates, but if it's below 1,000 IU per liter, then you are doing a good job, and that liver is functioning effectively. It's suitable for transplant, and that's why utilization rates are so incredibly high, and early graft failure, early graft dysfunction, these biliary lesions are coming down to these very acceptable levels. So it really works well for the liver. Let us take into consideration the kidneys. Delayed graft function rates are significantly lower in NRP compared to traditional DCD with super rapid recovery. So you see a significant improvement in early, essentially, functionality of the organ post-transplant. This is very, very, very significant, as you can easily see. It gives you the ability to evaluate via macroscopic aspect. They can look at the kidney again. We can measure urine output, which I frequently like to do. I make sure that the urimeter or the urine bag is in a place where I can see it, and I want to see urine being made. It really makes me feel good about what I'm doing and that I'm doing well, okay? Because the kidneys can be, although urine output is not, in and of itself, a perfect assessor of kidney function.
Correct.
If you are making urine, it is a good indicator that the kidney's working. If you're not making urine, it is not in and of itself a great indication that the kidney is not functioning well. So you have to take that into consideration because we are taking away pulsatility, physiologic pulsatility, and there's a lot of other factors that are involved with this. However, I would say 90%, maybe 85% of all the cases that I've done where I always measure the urine, I've made urine. So that's something that matters to me. The absence of urine output during NRP is frequent and should not be, says it right there, sole metric for organ discard.
There you go.
There you go. So it actually does tell us this, and you'll see my references where that comes from as well. Now let's look at the heart. Very interesting, I'll tell you. For the heart, it makes the most sense. It really does. Let's see. I think for a normal person, AST levels 45 to 60 normal, but less than 1,000 being normal for NRP is an interesting fact. Yes, it is. But it's also, I think it was ALT, not AST. It's ALT level.
Yeah, it is ALT. It should be ALT.
Right.
Also, he was asking what is meant by fail-safe.
Fail-safe? What is meant by fail-safe? In other words, you've created an environment that you know you are not. So venting let's say you clamp supraciliac and you then open the aorta above it. Well, if there's no blood coming out of it, that's your fail-safe to know your clamp is occlusive and there's not some other weird vessel going somewhere back up into the ascending aorta or up to the head. So that's basically what that means. So that would be the case if you clamp the head vessels to vent those as well, because that, if you don't see blood, if you see blood coming out of any hole you put above those clamps of the arch vessels, then you can pretty much assume that I am getting blood flow up to the brain from somewhere, where I would have no idea, but it can happen. And so that's the fail-safe, if you will. So kidneys, again, it has excellent outcomes associated with that. Something that we should, telling us that NRP is really far better than super rapid recovery. Clinical outcomes for the heart, going back to this, you can really assess the heart. And and so look at this survival parity chart, 100% 30-day survival with TA-NRP. It achieves post-transplant survival parity with expensive direct procurement and perfusion, DPP methods, which is what's it called? The heart in the box. What's the thing called?
Transmedics.
Transmedics, yeah. The Transmedics box. So the difference is that if you take the organ, take the heart, and put it on Transmedics, you are going to perfuse it. That's true.
You will.
No question about it. However, you never had the opportunity to assess it. And at that point in time, your only ability to assess it will be after it has been transplanted in a patient.
Yeah.
With NRP, you can do echoes. You can look at the heart. You can fill the heart and see how it does under load. You can assess the valves. You can assess everything about that organ. So TA-NRP for cardiac resuscitation for and restoration for then static cold storage and transplant is far superior, in my opinion, and I believe the data supports my opinion, far better than using Transmedics.
Sure.
Far better.
Yeah, I mean, Transmedics is just a great way to transport.
And what's interesting, but is it really? And I'll tell you why. Let's talk about that real quick if we
I would
can.
love to, actually.
Yeah, that's a really good concept. So right now, I think the person with the longest amount of time of cold static storage following NRP with a superb outcome for a heart transplant is Matt.
I remember
Matt Warhover.
He told us.
And I believe it was greater than 10 hours.
It was. He talked about it on one of our programs where he was on there. I
So
remember that. Yeah.
we have historically had a 4-hour from explant to implant on hearts. That was historical for years and years and years.
I think he said they were going to Alaska or something.
They were in
Yeah,
Alaska.
they were in Alaska.
And they had to get all the way to Nashville.
Right. Yep. I remember
And it
that.
was a 10-hour trip.
Yep.
From the time it was explanted to the time it was greater than 10 hours. And they had superb results. And I think that is just that is incredible when you think about it. That's absolutely incredible. But anyway, allows the donor heart to be evaluated in situ in a familiar physiological grounded environment before procurement. We discussed that. Multidisciplinary benefit, perfuses the heart and abdominal organs concomitantly, maximizing the donor's anatomical gift. So how many organs you can take, because you can essentially perfuse the entire body, restore all of the organs with the one cannulation up in the chest, and still isolate the cerebral circulation and essentially make available to patients needing transplant to survive just that much greater. So system evaluation in situ NRP versus ex vivo machine, which is the Transmedics. In the in situ group, simultaneous resuscitation of multiple organs, in vivo reversal before procurement, and low cost, high multi-organ yield. With static cold storage, you have limited single organ focus, does not reverse or minimize damage that has already occurred, and low initial cost but high discard rate, which is very bad. It's horrible for the patients that are waiting for transplant to think they're going to get one, and it costs the system a whole lot more money. The HOPE trial ex vivo single organ per machine sequential ex vivo reversal post procurement, so you don't ever have, you do not have in situ. High per organ machine and reduced cost. These things are they're very expensive. I can't remember the exact number, but I think it's like $85,000 to put the heart on a Transmedics device.
Yeah, that's why they think about it 100 times before they open that disposable kit, which costs
Yes.
the $85,000.
Yes, and then in NMP ex vivo, which is again the similar to the box, single organ per machine sequential, ex vivo reversal post procurement, and high per organ machine cost and resource, high machine and resource cost. So, you know, really you look at these, and NRP stands out, in my opinion, as being far superior to doing things with the ex vivo boxes. I really think it makes a big difference.
Ex vivo boxes also use a lot of bank blood. It's a lot of, like, I don't know. It's
They really do.
like a lot. Like,
Absolutely.
I'm not going to say the number, but we all know the number. It's a lot.
Yes.
Like-
Now you can, and I've seen this happen many times, where you take the you do NRP and then you still put the organ on
Oh yeah, that's catching on.
the
by way.
Transmedics. Well,
That's
there's a
catching on.
reason it's catching on. There's a reason why they do it for the livers.
Okay, I would love to know that because I'm seeing that more and more and more.
Yes, because they can harvest multiple organs, multiple livers from different donors, take them to their facility, and have them in a room lined up and be able to operate on their series of patients that are waiting for transplant.
Yeah,
So when organs are available, they want it, and they'll keep it on the Transmedics device so that they can then controlled in a calm way get their patient in, get them set up for surgery. You're getting this liver, you're getting this liver, you're getting this liver.
Yeah, there's a hospital in Florida. I don't want to say which one because I don't know how they'll feel about it. But yeah, they use Organox, and I've heard the same thing. They just have a room that's just filled with livers on these Organox machines, and that's kind of how it is.
Yeah.
But yeah.
Yes, absolutely. Ox says, I think I have read somewhere in some article by OCS or Transmedics, coronary sinus saturation indices within 4 to 5 minutes of putting on OCS and after giving inotropy if required on OCS is an indicator of perfusion. Yeah, well, Ox, yes, that's perfusion. I agree with you 100%. We're talking two different things here.
Yeah.
There's perfusion and there's function.
Right.
So yes, the OCS pump is going to perfuse that heart. There's no question about it. That heart is going to be perfused. But if you do super rapid recovery after cardiac death, after DC, so DCD, not DBD, we're talking DCD, that you have the warm agonal phase, if they die within their time frame for OCS, or Transmedics, whichever you want to call it, you die within that time frame, you go in there and do super rapid recovery, put it on the device, and start perfusing it. That only now tells you, if you measure coronary sinus, SpO2, or saturation, that you're perfusing the organ, and that the organ is extracting oxygen, or how much oxygen, or whatever the case may be that you're trying to assess. But you can't load the heart. You can't actually check its function. You can't even do the valve. You can't look at the valves. You can't look at anything. Yeah. So if during that period of time that you were in your agonal phase, you ended up having an infarction, you wouldn't even know it. And you could potentially end up with a heart that didn't have mitral regurgitation
But now does.
preoperatively that now
That
does.
now does, right?
So you've really got to, that's the reason. So yes, I read that too, and that is correct. That is what they do, but that only tells you you're providing that organ oxygenated blood and that the organ is extracting oxygen from the blood. That's all it tells you. And then, of course, the ethical landscape, you have utility and non-malfeasance as a requirement. You have the dead donor rule and public trust. And essentially, this really comes down to that you have to have irreversible cessation of circulatory and respiratory functions. The controversy is that critics like the ACP argue that restoring regional circulation via ECMO or NRP violates this irreversibility, challenging the boundaries of the dead donor rule. I don't agree with that at all. I just simply do not. I think that's I think that's a red herring as well. If you are brain dead, you are brain dead, and so your period, your agonal phase, the brain, although the brain will take whatever oxygen it can possibly get, if your perfusion pressure is too low, strokes are going to start occurring, and then you do have total cessation of circulation, and you're warm. It's not like they're in a cold environment. They're not submerged in ice water. They're in a warm environment, and they're warm, and you completely cease all circulation to the brain for 5 minutes before you touch them, and then it takes you another 5 minutes to initiate recirculation, and before you initiate that recirculation, you have clamped all of the head vessels. I really, truly consider that irreversible. Irreversible brain death. That's all there is to it. The other organs, and this is the beauty, I guess, of our biology, is that the brain is extremely sensitive to hypoxemia. Extremely sensitive. Our other organs can tolerate it for quite a while and still not have irreversible injury. You can reverse it. So with that said, I do not have an ethical problem with this at all. If I have an ethical issue, it is with how we treat the donor, which we don't have to do at all because there is a rule, and that rule is we cannot be anywhere near that patient. We cannot be in the same room as that patient, much less touch that patient until the 5-minute standoff period has occurred, and there is clearly, at that point in time, death has ensued. So
that rule is not always followed, Joe. I'm just going to say that. We all know that.
Yeah,
But
we're not going to talk about that.
No, we're not.
But that is the rule, and it's there for a reason.
Yeah.
And I am a strict adherer to that rule.
Yes.
I am.
I agree. I like that. That's
And
a
I
good
think
rule.
you are too.
Yes. It's a good rule.
And that's what the rule is there for.
Yeah.
So we're not even in the same room where they withdraw life support. We don't touch the patient at all. We don't even see the patient prior to this, which makes it somewhat impersonal, but probably protects us to some degree, our psychology, because again, we're dealing with death, but we're dealing with life at the same time.
Exactly.
Because you cannot in any way minimize the impact that this has on so many lives of people who need either a heart, lungs, liver, kidneys. I mean, in theory, you can help 1, 2, actually more than that, 1, 2, 3, 4, 5, 6. You can, in theory, help 6 people.
Oh, yeah.
With one donor.
One donor, yeah. For me, some people will say, oh, you're being insensitive to death. No, it's not that to me. to me, I like to put a clear boundary between the death aspect and the life aspect.
Hmm.
And in actuality, I'm supposed to be more concentrated on the life aspect because I'm part of the team
Hmm.
that's going to recover the organs.
Yes.
You know, and that's why I like that rule, the rule we just said, the no touch, we don't see. Again, it's not that I'm being insensitive to the patient that is passing away. It's more my job is to facilitate those organs which were they were given to us through the wishes of said patient.
Yes.
And my job is to facilitate getting those organs to those 6 people
Yes.
in a timely fashion,
Yes.
you know?
And in as good a condition as is possible,
possible,
so
correct.
that the graft continues to work and
Correct.
function after it
Right.
has been implanted in them.
Right, exactly.
You're going to have a tremendous impact on many other people's lives
Yep.
from that one tragic event.
Exactly.
Yes, I think that's the only way I can look at it.
Yeah, people get so concentrated, you know, on the death aspect, especially when it comes to the NRP. You know, oh, well, you're vultures, you're this, you're that. You know what I mean? You're just waiting around for a patient to die. Well, that's not always true. You know,
No.
that's not true at all. In fact,
No.
Yes, we have to wait for the patient to die. We can't take the organs until they're dead.
Yes.
You know,
And we cannot hasten their death.
and we cannot hasten their death. Exactly.
Correct.
So yeah.
Very true. Very true. So, resolving the controversy of irreversibility versus permanence, really, that's what we had talked about just a moment ago. You have irreversibility, and then you have permanence. And the difference between those two is that you cannot reverse something by any known medical intervention versus will not be reversed because there is no intent or consent to resuscitate the whole person. That's permanence. And so there is a distinction between those two things from a medical ethical perspective. And the defense for NRP is the transplant community argues that death relies on permanence because the donor family consented to withdrawal of life support and organ donation, and because life support will not be resumed, circulatory cessation is in fact permanent. The localized nature of NRP combined with absolute prevention of brain reperfusion ensures the donor remains legally and biologically dead throughout the procedure. So, operationalizing safety, transparency, and trust. Protocol 1, strict adherence to the 2 to 5 minute standoff time. For us, it's 5 minutes.
Yeah.
Post-asystole to independently confirm death prior to any intervention. Absolute technical precision in aortic venting and arch vessel ligation to mechanically prevent any cerebral blood flow. Transparent, informed consent. Donor families must be explicitly informed of the mechanics of NRP, including the disclosure that the heart may resume beating during thoracic NRP. Very important. But there's so many mechanisms in place to bridge the divide between need or between hope and tragedy. That's the reality.
Yeah, that is the reality.
You know, and there are many of these families who the only hope they can find in the tragedy is that that person, their loved one, left this earth helping others.
Correct.
And that's so powerful.
Yeah,
It really is.
it is.
It's powerful. Normothermic regional perfusion bridges the gap between tragedy. Look at that. I didn't even, I wrote the slide. I forgot. Transforming the limits of organ viability through in situ
I'm sure you knew where I
resuscitation
was going.
while upholding the highest ethical standards of donor. I just thought y'all would think I was smart. And here are my references. And that's it for that. Okay, you want to beat this up a little bit?
Where to start? I mean, we can beat it up in all kinds of ways.
Well, what's been your experience thus far? Not necessarily, focusing on the
Negatives?
on the negatives, but how
No,
about
the
on
positive.
the Well, on the positives and
I just love when you have that case where, you get on pump, you pull that first gas, and you check that first lactate, and it's like 16, and then that last one right before you come off, you check it, and it's like 4. That's a great feeling.
yes,
You know what I
yes,
mean?
absolutely.
That's a good feeling. I mean, that just to know that you helped that, or
Because that's telling you that the liver is functioning.
is functioning.
Now,
and
you can-
you cleared out a lot of the bad stuff and left it with a bunch of good stuff, and that liver is not only functioning, but you have made it better, and for whoever is going to receive it, you have done a good service.
Absolutely.
So,
But
and the converse also can happen, obviously, but I like to know that we make somewhat of a difference in what we do, and I believe we do because I look at that first gas and I see that 16, and I know that that's what would have gone to the patient if it were a rapid recovery. Maybe not quite a 16, maybe a little bit less, minus a few minutes here and there, because our process is a little bit longer to get onto pump than the rapid recovery would be. They're flushing pretty quickly on rapids for the most part nowadays. I've seen a few. You're pretty much, it doesn't take long for them to get that cold flush in nowadays. But still, I mean, just to know that, especially in the cases where your warm ischemic time is long, where they hang out agonal for like 25, 30, 40, 45 minutes. I mean, we've seen some of these COPD patients that can ride out these low sats forever.
Yes.
You know what I mean? Like some of them don't even pass.
yes,
Some of them will sit at a saturation of 25 and the systolic blood, a systolic about 70, and then they'll ride that out for 90 minutes.
yeah,
And stay steady like a rock throughout the entire time. I'm sure their organs are not loving that, but it's good to know that we make a difference in those types of patients.
Absolutely.
in the patients where they have those long.
yeah.
warm
For me,
ischemic
the
times.
biggest tragedy, if you really want to know how I feel, for me, the biggest tragedy is when we pass the time they haven't passed, and they're going to be put right then. They go straight to hospice. They are never given any additional care, and they are going to still pass.
Yes, I agree.
But we were unable to take any of their organs. And so, to me, that's the biggest tragedy. And I think that's
That
the
is a big
hardest on the
tragedy.
families.
I believe so.
That's
too.
just sad.
Even worse than that is when they are starting to decline, and you do hit that
Yes.
time mark.
Yes.
And if you would have had 10 to 15 more minutes, that you would be in the OR.
Absolutely.
You know what I mean? And you're just looking at it like, well, that's just a waste of good organs. You know what I
Yes.
mean? Especially if they weren't agonal, and all of a sudden we're starting to decline.
Yes.
And
Yes.
you know that those organs would have been decent. But I get it. I mean, the rules are in place for a reason. Where do you draw the line? When do you make the call? You know what I mean? How long do you sit waiting?
Yes.
How many resources do you burn for a possible patient that might not pass, like these?
That day.
Yeah,
Could be
that
2
day.
days
It
from
could
then.
be 2 days
Right,
from
that
then,
can happen.
especially some of these chronically ill patients.
Yes,
that
there's no way to
that can
predict.
ride it out forever.
Absolutely.
So
Hey, David, so I have this next, and so I have until 1:30. Okay, so, and it's already 4 to 1, 4 minutes to
Yes.
1. Okay, so we need to get started.
we do.
We're going to talk about ultrafiltration during cardiopulmonary
I
bypass.
do like
Why?
that ultrafiltration. You can get through it pretty quickly because you know it so well.
Yeah. Why are we still debating this? Why? Okay.
I mean, you've done like 8 programs on it that I know of.
Yeah. Early cardiopulmonary bypass protocols necessitated mechanical hemoconcentration to combat severe hemodilution. Now, our pumps have gotten better. Our hemodilutional load has gotten less, but it's still too much. The problem, early CPB struggled with massive fluid shifts and severe hemodilution. Man, we used to take all of our patients out of the operating room back in the old days, and they were just all swollen. They just looked horrible. And then they would just, they'll mobilize it, they'll shift it or whatever. And most of them did, interestingly enough. But Our transfusion rates were almost always much higher. There was a lot of other issues. And our outcomes were not nearly what they are now. They were good, but not nearly as good as they are now. The necessity of mechanical hemoconcentration devices were integrated as a fundamental clinical requirement to manage these profound volume shifts and prevent dilutional anemia. Now, I'm going to tell you right now before we go any further, because next set of lectures I'm going to be talking about albumin. That is only true if you can reclaim the shifted volume.
Yes.
You can be grossly hypoalbuminemic, anemic, have all this water in the interstitium, and still not get it if you don't fix the underlying cause that sent the volume out into the extravascular space. Modern ultrafiltration strategies evolved to aggressively modulate the systemic inflammatory cascade. And now, I will say that this is a very important concept. Number one, ultrafiltration does not mitigate the inflammatory cascade. That is incorrect, because your ultrafiltrate is isoosmotic to what is in the plasma water. Therefore, the concentration of whatever it is you are removing remains the same within the system, within the patient's blood volume, as it was before you ultrafiltrated. You have to perform CVVH or ZBuff, if that's what you prefer to call it, if you want to impact the volume of, or the percentage, or the level of whatever evil humor you are trying to remove, or ion for that matter that you're trying to remove. If you have a potassium of 7, I can ultrafiltrate 3 liters. The potassium will still be 7. I have to replace it with something that doesn't have potassium in order to affect a change.
You have to create a gradient.
And that's not a gradient. No, you have 2 tanks. So I have 2 cups. And let me see if I can, I don't know.
Oh, you're talking about the dilutional effect of ZBuff.
Correct.
Yeah.
Correct.
Yeah.
If you have
Right.
here, the potassium is 7. You have a hemoconcentrator here. The ultrafiltrate will be 7. And neither will change.
Correct, yeah.
But if I replace in the patient something that has 0 potassium, as I am removing the ultrafiltrate, then you dilute this potassium down. That's how that
the
works.
dilutional effect, yeah.
Okay?
Yeah.
So the hemofilter establishes a selective transmembrane pressure gradient at a 20 to 30 kDa kilodalton threshold. It has actually a pore size of 50 kDa. However, in order to get that out, you have to have convection, and your sieving coefficient will be lower. Now, it will not remove protein-bound inflammatory mediators, only those that are circulating. That's
Only free
that are
flowing.
correct,
Yeah.
that are not
Not bound.
protein-bound.
Yeah,
Right.
'cause
So
protein
there
won't
is
go
a
through the-
difference between passive and convective. So you're depending on a pressure gradient. If you're running this through your arterial system, you have a higher pressure here than you have on this side, and the fluid will be pushed across. However, the higher this gradient becomes, the larger the molecules you can remove. Does that make sense?
Yeah, that makes sense. Yeah.
Okay. And that's why when I do CVVH, I cc's a roller pump to pump the blood through my hemoconcentrator and get the flow up to about 700 cc's a minute. And I use the Neptune for the effluent.
So
And-
come out at the same rate.
Yes,
Yeah.
and that gradient, that really strong gradient, convective gradient, pushes greater than 30 kilodalton molecules through those pores that are 50 kilodaltons. Now, if it's 5 kilodaltons, you can imagine it's going to free flow.
Oh,
That's
yeah,
just
yeah,
easy,
yeah,
right?
yeah, right.
7 kilodaltons, no problem.
Yeah.
So potassium, chloride, sodium, all that
that,
stuff
yep.
goes back and forth very, very
Correct,
easily.
Correct.
But when you're talking about IL-3, IL-8, TNF alpha, tumor necrosis factor, all that stuff, those are much larger.
Right.
And your sieving coefficient will be much lower. But you can augment that sieving coefficient by having a high pressure gradient across the actual fibers themselves,
the
the
membrane
pores
itself, yeah.
themselves. So cuff is essentially continuous ultrafiltration. It says conventional, but it's continuous ultrafiltration. MUF is modified ultrafiltration. That is, you've come off bypass, you drain out of your arterial, you run it through a hemoconcentrator and you pump it back in the venous, or you could do it a different way if you want to, whatever configuration. That's normally the configuration that I've seen doing it that way. So it's done immediately post bypass, and it was an interesting trick in its day. I don't see that as being useful now. I think pediatrics may use
They
it,
still do it quite a bit.
but in adults, I don't really see that as making sense. And then you have zero balance ultrafiltration, which is very similar to CVVH, which is continuous veno-veno hemofiltration, even though it's in the pump, but different issue. Essentially, it's the same thing. The question is, what volume do you use as your replacement volume? And that's extremely important. If you use sodium chloride, you have to add bicarb. Your sodium goes up. Your bicarb is constantly needing to be adjusted, and it becomes a very challenging thing. You're also only, you're taking out glucose, you're taking out potassium, of course, you're taking out lactate, you're removing bicarb, so you're having to replace that. But you're not replacing magnesium, you're removing that, you're removing phosphates, so you're removing everything, especially these small molecules, very rapidly. And if you don't use a replacement fluid that has the constituents of what you want the plasma water to look like, then you miss the boat.
I know where you're going with
right? Exactly. So clinical trials confirm the precise mechanical efficacy and physiologic benefit of hemoconcentration. In cuff, you're basically doing this for nothing but to raise the hematocrit. And Monjero actually showed this with 2.5 liters removal. Now, if you have a blood volume, and we've talked about this ad nauseum, but if you have a blood volume of 5 liters and you take 2.5 liters out, well, either you are hypervolemic, because if you take 2.5 liters out of a 5-liter tank, you're going to be hypotensive, tachycardic, the patient will be in shock, right? So you have to treat, you have to make sure you are not allowing for third spaced volume to remain third spaced, or you cannot remove this much for obvious reasons. It's just so intuitive, makes so much sense, but people have such a hard time understanding this concept. In MUF, the decreased morbidity, reduced pulmonary vascular resistance, reduced postoperative bleeding, I think this is all secondary to just decreased hemodilution. Okay, because you've taken a hemodiluted pump, you've pumped all the blood into the patient, and now they're hypervolemic intravascularly, and you want to remove that volume postoperatively, or so you could keep getting the rest of your pump volume in, which is your red cells, your platelets, your plasma, and all of that stuff. Cell Saver is a great device, should always be used, but it is no panacea. It can do real harm if misused, like everything that we do. Retrospective observations suggest an association between high volume ultrafiltration and renal injury. This is very interesting. It's the Manning Report 2021, 1,600 adult elective cardiac surgery patients. The claim is that conventional ultrafiltration volumes exceeding 32 milliliters per kilogram increase the risk of postoperative acute kidney injury. Now, I call bullshit. Because it just really depends on how much volume the patient has been given. With the advent of Del Nido now, where we give 1,200 cc's, 1,500 cc's, sometimes a second dose, 2,500 cc's, you can see where just simply the cardioplegia will exceed the 32 milliliters per kilogram, number one. Number two, what is your pump prime volume? You have to take that into consideration. You have to take into consideration how much volume did anesthesia give. You have to take into consideration, did this patient come to us very dried out from diuretics and days in the hospital and all of that stuff? Or did this patient come to us euvolemic? Did this patient come to us from the cath lab where they were given tremendous boluses of volume and they're actually hypervolemic already? Again, this is an arbitrary number, and I consider it to be fundamentally wrong. And then you have the Stammers registry, who is equal in wrongness to our previous slide. This registry reviews correlated zero balance techniques with a significant decrease in postoperative urine output. We just saw, and it was very, very good data, by the way, because we transplant these organs, that urine output is not a great measure of renal function.
Correct.
So if you're measuring a patient who goes to the ICU with a massive fluid water overload, and they have to be diuresed, and you bring another patient who is not severely fluid overloaded and doesn't need to be diuresed, well, of course, the urine outputs are going to be different.
Right.
And this was, of course, a retrospective. It was multiple centers. It was done through a corporate entity. And this has thrown a wrench in the gears like nothing else I've ever seen do that with something that is so incredibly fundamentally flawed. And I think that if I had the ability to sanction both Manning and Stammers for what I consider to be known bad science and publishing it, thinking that this is going to have some effect on everybody's practice, knowing it would have an effect on everybody's practice and hurt patients, I would. But I can't, so I won't. But if I could, I would. This should be reviewed, dismissed, and it should come with a saying on it that says, "This is truly bad science." The association, was that too strong?
You should have just said it with an asterisk.
With an asterisk.
There you go.
The association between ultrafiltration and renal injury is driven by confounding indications: severe baseline morbidity and prolonged CPB. And in reality, observational studies have failed to isolate hemofiltration as an independent variable. The clinical state dictates the intervention. The intervention does not dictate the injury. This is really fundamentally how I feel. Okay? And your driver for acute kidney injury or God forbid, acute renal failure needing new dialysis is your baseline morbidity and severely prolonged CPB. As I told you, the pump is not good for anybody. The less time you spend on it, the better you're going to be. But if you don't fix the underlying problem, well, then you have no hope of living. So It's which poison do you want to take?
The one that's going to kill
And
you
what
right
can
away,
we
or-
do
yeah.
to make it better?
Exactly.
These prolonged CPB times, I believe, are mitigated with the use of CVVH.
Right.
This is why I do it.
Yeah.
Retrospective study designs fail to isolate critical disparities in baseline surgical complexity. In the Manning cohort, for example, patients requiring greater than 32 milliliters of ultrafiltration exhibited significant longer cross-clamp times and inherently higher baseline morbidity prior to surgery. And in the Stammers cohort, the Z-Buff group received nearly double the asanguineous volume in crystalloid cardioplegia compared to the non-ultrafiltration group. So there you go. Postoperative acute kidney injury is overwhelmingly a product of prolonged extracorporeal circulation, microembolic load, loss of pulsatile flow, and you cannot underestimate that. And if you think the pump, the Essence, which I believe I use the Essence heart-lung machine, and it does its best, absolute best job it can to create a pulse. I feel that pulse generation is so aphysiologic, number one, and number two, the pressure, the hostile pressures that occur and the pressure swings, in my opinion, are far more deleterious than the loss of pulsatility. And although our bodies will adapt,
just doesn't look the same, obviously.
No,
right?
it doesn't.
Like, it's so off.
It does. Well, you're
It's
also
never just like a perfect curve like that.
no.
Like-
Remember, you're taking well. First of all, a normal pulse generates two things. You have one, the initial outflow of volume from the ventricle going into the arterial
Correct.
tree, and you have an expansion of those vessels.
Yeah.
But your pressure is going up.
Right.
But you then have what's called surplus hemodynamic
Right.
energy, and that
The
is
return.
caused by the rebound of the blood vessels
Yeah.
as they are emptying, and this helps with the capillary opening pressure at the end organ level. Now,
Right.
humans are beautiful at adapting. So over time, because you look at the total artificial heart, it's a continuous flow pump. You have no pulse.
Right.
Over time. And acute kidney injury does not mean acute kidney failure.
Correct.
There is a distinction between the two.
Right.
So with that said, you just simply are, and in my opinion, far better off using continuous flow on the pump, because I've seen pressures exceed 450 with a pulse pressure. In other words, the line pressure, not the patient pulse pressure, but the line pressure in your arterial line where you're measuring it, both the peak and the drop, is more than 350, almost 400 millimeters of mercury. And that is very concerning to me. Not to mention, you're trying to take something that should be pumping into 2.5 to 3 centimeters, and you're putting it through a 7 millimeter cannula tip.
Right.
So think about what that does and the kind of jetting that takes place.
Right.
So I have a real problem with that. So with that said, non-randomized studies lack objective rigor, and the result, the renal insult, stems directly from the mechanical realities of the bypass run, not the application of hemo concentration or the hemofilter. Large-scale meta-analyses definitively prove ultrafiltration does not increase the risk of acute injury. Here are the studies, and you can see here your relative risk, and it favors, I'm so sorry, it favors on this side the use of ultrafiltration. We're going to run out of time. I'm not going to be able to finish all of it. So we're going to do part 1, and then I'll do part 2 another day. Statistical pooling reveals ultrafiltration drives significant systemic benefits beyond renal safety. When you look at this meta-analysis from Wang, decreased perioperative bleeding, decreased packed red blood cell transfusion, and shorter lengths of stay. Also, zero increase in major adverse renal events. Ultrafiltration is the necessary intervention for a deteriorating clinical, not picture, not the primary etiology of the insult. The persistent debate relies on a statistical illusion. When corrected for confounding factors by indication, the evidence is unequivocal. Modern ultrafiltration modalities safely manage hemodilution, modulate the inflammatory cascade, if done properly, and improve postoperative outcomes. And here are my academic references. Okay. All right. So, you want to talk about ultrafiltration?
Oh yeah, I'm a fan. I've told you that before. I've called you regarding some of my own personal, ultrafiltration techniques that more specifically, I remember I used to call you about it when I first started practicing perfusion. About specifically, I think I brought up a case where I had pump lung, if you remember, and I wanted to talk about better ways of minimizing pump lung.
Yes.
Coming off pump. If you remember, I called you just randomly about it. I'd called you right after my case, where we almost ended up on VV ECMO, but we didn't. The pump lung did end up residing. We had to sit in the OR, post-operatively for about 3 hours, but it did subside, and we didn't have to go on.
But I think, and that could have been caused from a variety of things,
and
certainly.
you told me that, yeah.
It
could
can.
be anything, yeah.
But, look at what happened just the other night. We were talking on the phone, and I was like, well, I mean, dude, have we checked have we checked an albumin?
Yeah, yeah.
And you were like, no, it hasn't. It's right. It was 1.7.
It was 1.7.
1.7. Do you think any fluid is going to stay in the vascular space?
I'm glad we ordered that CMP.
And what happens? You start to chatter.
Yep.
But they're swelling up, and you give more volume. And then the chattering.
That's exactly what I had told you. I was like, my patient is starting to swell up. I had noticed that.
Yes.
I noticed the fingers were getting fatter.
Absolutely.
And I was like, okay, my patient's starting to swell up. I'm not chattering yet.
You're going to.
But I was going to, right.
Yes.
Yeah,
and then you give volume and more volume and more volume, and they swell up more and more and more.
Right.
And it's just, and then all of a sudden you have microcapillary compartment syndrome globally.
Yeah.
Globally.
Oh, this was about to go downhill quickly.
There was a phrase that exactly. There was a phrase somebody taught me one time. I can't remember who taught me this, but it was anasarca, or just generalized severe anemia, where the eyeballs, they look like water balloons, the ears, the face, the eyes are swollen shut, the tongue's out of the mouth, your arms and your legs, everything is just swollen. They just look like a Michelin man, right? They just
like
swollen. That's anasarca.
Yeah.
And so what he said to me was, anasarca is not just a visually displeasing finding. So what that means is, if this is what you're seeing on the outside,
imagine what's happening on the inside.
The organs look like that.
Yes, exactly.
And so if this pump lung phenomenon can be just simply the lungs accumulating fluid from a severe hypooncotic state, and then you have these stiff lungs when you're trying to come off bypass, and everybody's like, well, why did that happen?
Yeah.
You mean there was no volume really going through the lungs at the time, but then you suddenly come off bypass and you start to get some blood going through there, you're hypooncotic, and all of a sudden you have this rush of volume. Now, could also be, that somewhere along the way there was increased capillary permeability, could be the inflammatory mediators that made their way in there and just caused some membrane leaks. Yeah. And all of a sudden, you have this capillary leak syndrome going on in the lungs. That could be it too.
It could have been so many different things.
Kind of like blood on the cell saver. Should we be washing all of our blood that we're allogeneic blood that we're going to give from the blood bank in the cell saver. Should we be doing CVVH on every patient that we have on cardiopulmonary bypass for more than, let's say, more than an hour? If it's longer than an hour, should we measure COP, which we used to do all the time, or albumin levels on bypass? Should we measure lactate levels on bypass every single case?
I think a bare minimum should at least measure albumin.
Yeah.
COP oncotic, maybe,
Well, it's about 70% of it's albumin.
Yeah. So you're right. So you getting the albumin tells you your COP.
Yeah.
At least a good portion of your COP.
Yes, but that can also be, red blood cell insufficiency. You're so anemic that even with a normal COP, normal albumin, your COP is still compromised because you don't have enough solid.
That's true.
So
I feel like we should, especially now more than before, especially with the rise of Del Nido and the use of Del Nido.
Yes.
With the rise of the use of Del Nido, I should say, I feel like we're dropping so much clear now in that. Now checking albumin has almost become imperative, but we don't do it naturally. We just, there are like I've told you, there are centers that don't even put albumin in their prime. Crazy as hell, but they don't, and they use Del Nido. So they'll use Del Nido and no albumin in the prime.
Yeah, exactly.
And then not check the albumin while on pump either.
I want to get your thoughts on this. Akash says. See, and if not, then what is the point? It's an indicator
I think he's
of
talking
fusion.
about the standoff.
And if not,
time.
then what is the point of standoff time? 2 to 5 minutes. The point of the standoff time for 2 to 5 minutes, Akash, is to make sure that the heart does not auto resuscitate. That's the reason.
And it has before. So
yes, and it has.
Yeah,
yes,
it has.
So we've gone from asystole to a rhythm with the blood pressure.
Yeah.
And that's the reason for the standoff period. And then his next question, this one I'm going to give to you. Okay. Use of ultrafiltration and vitamin C or sodium ascorbate as an anti-inflammatory mediator can serve great. That's a good idea.
That is a good idea, and it's so widely available too.
But the problem is that so you have to tell us about the timing on that, because to the best of my knowledge, vitamin C or sodium ascorbate will be removed very rapidly through the ultrafiltration. Those are some pretty small molecules.
Those are really small molecules. So it does depend on when you're going to do it. If you do it
unless it's in your ultrafiltrate, it's in your replacement fluid.
I would put it on. I would put it in after
you've
done ultrafiltrating.
Yeah.
Give a bolus of it while, I would imagine, right before clamp is going to come off is probably a really good time.
Yeah.
Specifically to help you when you're coming off bypass.
Or have it injected into your replacement fluid bag, which is you don't want to use Normasol, you don't want to use Plasmolite, you don't want to use sodium chloride, you don't want to use ractated lingers. You want to use either the next stage fluid or the Braun fluid, Duasol, Duasol and Prismasate, and the next stage has their own version of whatever this fluid is, but it's a bicarb-based fluid that you can get various different formulas, and you pick the formula that you want the plasma water to look like. Also, but you can add stuff to it.
Yeah. Also, you can give it at the beginning. You could probably give it 2 different times, in fact, because it is vitamin C, and it can be given more than once.
Yeah, there's no overdose.
Right at the beginning. You could even probably add it to your prime to try to help offset the inflammatory response that's going to come when you initiate bypass. It just depends again on what you're trying to accomplish.
So let's see, Sauron, when you stop hemoconcentration, do you stop blood from circulating through the hemofilter, or do you only close its outlet? Really good question. So my technique is, when I know we're going to come off bypass and I have my volume exactly where I want it to be by the time we get to that point, then what I do is I will clamp my line, remove the line going from the high pressure line into the hemoconcentrator, let that blood all drain back into my system,
You'll literally
and
hang it
then
like this and
no,
let
I
it
don't hang it quite like
drain.
that. I don't do that.
No, he doesn't do
I'm a little more better than that. And then I just put it back on because if I do want to use it again, if something happens, I can. But I get that volume back in the patient. Some of my colleagues, the way our system is designed, they run the crystalloid, so it doesn't go into the pump, but it goes through the hemoconcentrator
through our research
antigrade and goes back into it, and they flush it out that way. You can do it either way. I mean, that's the way that's the technique that I use, is just to drain it out. They use that technique. I think
it doesn't introduce any more crystalloid, whereas as the otherwise, you always are going to get some crystalloid.
Yeah, it's probably insignificant.
It is insignificant.
And actually,
it's a push anyway.
Yeah,
you'll know when you're not red no more.
Yes,
right?
and I think that's probably the better technique. Actually, I might change the way I do it just because of that. I think it's a better idea.
I don't like this connecting thing, so I usually just
Yeah, well, when you forget what you do and you forgot to clamp the line, you remember, you don't ever forget again.
I'm in our company. I'm known as the mess maker.
So anyway, so that's what I do. Is once I'm done hemoconcentrating, I'll drain the system either way, whether it be to empty it completely or to flush it through. I think both techniques work, but at the end of the day, I think his technique is better than mine, and I'll probably change.
I like this. Can we
say that again?
I like what Ox wrote. And next,
can we have an engineered vitamin C molecules to a particle that can prevent?
So we'd have to bind it to something that's big. Like
well, it's water. It's a water soluble vitamin. Akash,
I mean, not going to make sense.
Come on, no, you can't do that.
That's why I liked it.
Water.
Can't.
That's why.
Unless it's your lipid solubles, vitamin D, A, K, and E. It's probably not gonna.
Yeah, and that's why you can't. That's why you can't overdose on vitamin C.
Exactly. That's why I was saying you can give it.
You're
twice.
just gonna
give it at the beginning and at the end. That way, if you give it at the beginning for the systemic inflammatory response that's going to come due to all the new lines and all the foreign surfaces, and you pull it off, you can just give it back again when you need it next time, which would be right about the time you're about to come off bypass.
I think that's a good idea too.
Because it's you can give it as much as you want. It's because it doesn't bind to proteins.
Right. I think all of these things are really good. I mean, it's I think that the key here, what I'm trying to accomplish, is get people thinking.
Yeah,
I think I have gotten people thinking.
Absolutely.
And Akash and Sauron, you know what? I'm glad because I feel like you guys interact with us, and it's so appreciated.
It is,
and you add real value. So keep it up and continue to be a part of this because I really appreciate it. I truly do. So thank you for that. And it's a really good idea, and I might have to look into that because I don't know enough about it, but I know it's good for anti-inflammatory processes, so it makes sense. Again, I'd like to learn more about it. Maybe we should be doing that.
I'm curious, and it's such a widely available thing. It's cheap. It's
not
like out of all the drugs we use, I mean, think about it. It's people are complaining about albumin. This is like pennies on the dollar.
Exactly. We could probably just get anesthesia to put some vitamin C tablets under the patient's tongue.
Yeah.
That's
better that way.
That's an idea. That's an idea. All right. Well, listen, you guys, it's been great talking to all of you. Thank you so much for today. And I'm going to do my second part of ultrafiltration because I have a whole bunch more, actually, another like 20 slides to go over of some really kind of cool stuff. So I'm just going to add it to the next program that we're going to do. And it's been great seeing everybody. Thank you very much. We'll talk to you later. We're going to be back on when? May 27th.
I'll be there for that. And I'll be leaving for India in a couple of days after.
That's right. And I'm going to have to come in remotely because I don't think I'm going to be here. So May 27th, we will see you all again. And thank you. Don't hesitate to send in ideas, suggestions. Again, we're going to do that pediatric program sometime towards the end of June or early July. Check out the adult ECMO specialist course that's coming up early June, whether it be just for the didactic or whether it be for the full program. We still have some seats left for the full program, but it does fill up fast. So if you know any nurses, ECMO specialists, respiratory therapists, maybe some of your nurse practitioners, PAs. It is appropriate for everyone, perfusionists, of course, if you really want to learn some really good skills with ECMO. It's an incredibly good course. I'm so incredibly proud of it. And we will look forward to seeing you all there at mediweb.us. That's the website. And that's it. Anything else?
No.
Okay.
Guys, see you next time.
Peace out.
Bye-bye.